I am Lynn, a DNP student at Bremen University. My PowerPoint presentation is about adults with chronic obstructive pulmonary disease or COPD. COPD is a preventable and treatable disease characterized by airflow limitation. It is usually progressive, not fully reversible, and associated with an abnormal inflammatory response of the lungs. COPD is a term used to describe two related lung diseases, chronic bronchitis and emphysema. For the purpose of this PowerPoint presentation, I will discuss about chronic bronchitis. Chronic bronchitis is defined as hypersecretion of mucus and a chronic productive cough that continues for at least 3 months of the year for at least 2 consecutive years. Inhaled irritants such as smoke, dust, and fumes cause airway inflammation with infiltration of neutrophils, macrophages, and lymphocytes into the bronchial wall. Continual bronchial inflammation causes bronchial edema and increases the size and the number of mucus glands and gallbladder cells in the airway epithelium. The inflammatory process continues even after withdrawal of prolonged exposure to the bronchial irritants. Tobacco smoke directly injures airway epithelial cells. Airway edema, airway wall thickening, excess production of mucus, and loss of ciliary function result. Therefore, when thick and tenacious mucus is produced, it cannot be cleared because of impaired ciliary function. For that reason, the lungs' defense mechanisms are compromised, increasing susceptibility to pulmonary infection, which contributes to airway injury. Frequent infectious exacerbations are complicated by bronchospasm with dyspnea and productive cough. Initially, chronic bronchitis affects only the larger bronchi, but eventually all airways are involved. The thick mucus and hypertrophic bronchial smooth muscle narrow the airways and lead to obstruction, particularly during expiration when the airways are constricted. Obstruction eventually leads to ventilation perfusion mismatch with hypoxia. Mucus plugs and narrow airways cause air trapping and hyperinflation on expiration. During inspiration, the airways are pulled open, allowing gas to flow past the obstructions. During the expiration, decreased elastic recoil of the bronchial walls results in collapse of the airways and prevents normal expiratory airflow. Hypercapnia results from the lack of ventilation. Cigarette smoking increases elastase activity by causing an influx of elastase-rich neutrophils into the alveoli and by causing the oxidative inactivation of antitrypsin. People who smoke have an increased 30-fold risk for developing COPD. Regardless of the mechanism, the end result of COPD is the destruction of the alveolar architecture and the capillary bed lying within the alveolar wall. Initially, the reduction in size of the vascular bed parallels the fall in the alveolar surface area. Ventilation still roughly matches perfusion, and significant hypoxemia does not ensure. As the disease progresses, the elastic recoil of the airway is lost, and the poorly supported non-cartilaginous airways collapse during expiration. As a result, expiratory flow rates fall, causing decreased airflow. Because of this, airflow obstruction is not uniform throughout the lungs. Uneven distribution of ventilation and poor perfusion occur. This uneven distribution causes arterial hypoxia, and decreased ventilation causes hypercapnia. Chronic hypoxia and hypercapnia increase pulmonary arterial resistance and may lead to the development of pulmonary hypertension and eventually choropulmonary. A sudden worsening of symptoms in severe chronic bronchitis can precipitate acute right-sided heart failure. The common symptoms of COPD include dyspnea, decreased exercise tolerance, wheezing, and shortness of breath. Individuals usually have a productive cough, and evidence of airway obstruction is shown by spirometry. Hypoxia may occur with exercise. As the disease progresses, copious amounts of sputum are produced, accompanied by frequent pulmonary infections. Forced vital capacity and forced expiratory volume in the first-second values become markedly reduced, and the functional residual capacity and residual volume measurements are increased as the airway obstruction and air trapping become more pronounced. In the late stage of COPD, the most common complaint is dyspnea on exertion. This symptom develops when irreversible changes may have already occurred. Other clinical presentations are clippings of the fingernails, cyanosis, bare chest, productive cough, recurrence of prolonged respiratory tract infections that have required antibiotics treatment. In severe cases, there is abnormal retraction of the interspaces during inspiration. Airway obstruction results in decreased alveolar ventilation and increased partial pressures of carbon dioxide. Marked hypoxemia leads to polysemia and cyanosis. If not reversed, hypoxia leads to pulmonary hypertension and eventually results in cor pulmonale and can lead to severe disability or death. As a future primary care provider, I selected the clinical practice guideline on the management of COPD that was developed particularly for primary care providers. It is an update of the 2007 clinical practice guideline. The system-wide goal of evidence-based clinical practice guidelines is to improve patient health and well-being. The overall expected outcome of successful implementation of these guidelines are to formulate an efficient and effective assessment of patient condition, optimize the use of therapy to reduce symptoms and enhance functionality, minimize preventable complications and mobility, and emphasize the use of personalized, proactive, patient-driven care. The intervention covered in this clinical practice guideline includes inhaled and systemic pharmacologic treatments as well as non-pharmacologic treatments used in acute and maintenance management of COPD. Pharmacologic interventions considered include various drugs such as long-acting beta-2 agonists, short-acting beta-2 agonists, short-acting antimuscarinic agents, long-acting antimuscarinic agents, inhaled corticosteroid, phosphodiesterase 4 inhibitors, chronic macrolide, theophylline, and acetylcysteine. The agents are considered either alone or in combination as part of step approach to managing the symptoms of COPD. This clinical practice guideline also considers the use of corticosteroids or antibiotics to treat COPD exacerbations. Non-pharmacologic interventions considered include pulmonary rehabilitation and interventions that comprise an overall disease management program for patients with COPD. This clinical practice guideline also considers the use of oxygen therapy and the use of non-invasive ventilation. This clinical practice guideline includes algorithms designed to best facilitate clinical decision-making for the management of COPD. A clinical algorithm diagram guideline recommendations and contents are described step by step. When a new patient with suspected or confirmed COPD presents at the primary care office, a provider performs a brief clinical assessment to determine if the patient is clinically stable or in an acute exacerbation. If the patient has an acute exacerbation, the management will be discussed in the algorithm B. If the patient does not have an acute exacerbation, a complete clinical assessment will be performed to determine a comorbid conditions by asking patients' history, such as tobacco use, activity level, exercise tolerance, symptom burden, and history of acute exacerbations. For examination, include pulse oximetry, wheezing, and use of accessory muscles, labor breathing, and BMI. For assessment for other diagnoses and comorbid conditions such as cardiovascular disease, CHF, pulmonary embolism, sleep disorders, abnormal nutritional status, GERD, depression, and anxiety. When patients are confirmed with COPD, then offer prevention and risk reduction methods including smoking cessation, vaccination, and patient education, and initiate or adjust COPD therapy. Consider the need to adjust medication in symptomatic COPD patients. For patients who are not already on medication, initiate short-acting beta-2 agonists for rescue therapy as needed. If the symptoms persist, consider inhaled long-acting anti-muscarinic agents as a first-line maintenance therapy. If there is no improvement, add long-active beta-2 agonists. If the symptoms still persist, consider adding inhaled corticosteroid as the third medication. Refer the patient to a pulmonologist when the symptoms are not released by the three medications. If the patients improve, continue to follow up, monitor, and reassess severity periodically. If patients with COPD require oxygen, measure daytime resting oxygen saturation. Provides long-term oxygen therapy for COPD patients with the following conditions: stable resting severe hypoxemia of equal or less than 88%, stable resting moderate hypoxemia from 88 to 90%, and with signs of tissue hypoxia such as hematocrit level less than 55%, core pulmonary or pulmonary hypertension. If the oxygen level is greater than 90%, continue to follow up, monitor, and reassess severity periodically. Another suggestion from the clinical practice guidelines is to provide other therapies for patients, which include providing supported self-management for selected high-risk patients, offering pulmonary rehabilitation to stable patients with exercise limitation despite pharmacologic treatment, offering breathing exercise to patients with dyspnea that limits physical activity, referral to a dietitian for medical nutritional therapy recommendation to support patients who are malnourished or BMI less than 20, offering consultation, screening, and management of overweight and obesity patients whose BMI is greater than 30, referral to a pulmonologist or palliative care specialist when appropriate for patients who are at the end of life. Algorithm B, the suggestion from the clinical practice guideline is to administer antibiotics for patients who have increased dyspnea and increased sputum purulence or volume. The choice of antibiotics is based on local resistance patterns and patient characteristics. The first-line antibiotic choice may include doxycycline, Bactrim or Cepra, the second generation, cephalosporin, Augmentin, and erythromycin. Broader spectrum antibiotics, such as quinolones, are specifically used for patients who are critically ill with a recent history of antibiotics resistance, treatment failure, antibiotic use, and with risk factors for healthcare-associated infections. A 5-day course of the selected antibiotic is recommended for patients who are treated with antibiotics. Another suggestion from the clinical practice guideline is a course of oral systemic corticosteroids of 30 to 40 milligrams prednisone equivalent daily for 5 to 7 days. Thank you for listening to my presentation.